Bismillahirrahmanirrahim. Today we are going Bismillahirrahmanirrahim. Today we are going to discuss our topic, that is ectopic pregnancy. Any pregnancy where the fertilized ovum gets implanted and develops in a site other than normal uterine pregnancy is defined as ectopic pregnancy. In simpler words, a conceptus implantation of a conceptus outside the uterine cavity is called ectopic pregnancy. It represents a serious hazard to a woman's health and reproductive potential, requiring prompt recognition and early aggressive intervention. Otherwise, we may lose a patient. This is a picture showing an ectopic pregnancy where the pregnancy is implanted in the fallopian tube, which is the most common site of ectopic pregnancy. The different implantation sites are extrauterine as well as intrauterine. In the uterine sites, if the implantation occurs in the cervical canal, if it occurs at the angular region, or if it occurs at the previous caesarean scar or at the corneal region, we would call it an ectopic pregnancy. The extrauterine sites are the fallopian tube, the ovarian, and the abdominal sites. Tubal ovarian ectopic pregnancy is the most common sites. Among the tubal ectopic pregnancy, ampullary region is the commonest site for an ectopic pregnancy. Then other sites in the tube are the isthmus ectopic pregnancy. It may represent as an interstitial ectopic pregnancy, or it may implant at the fimbrial end. In the abdominal pregnancy, the ectopic pregnancy can be a primary as de novo, or it can be secondary, where the tubal ectopic pregnancy aborts at the fimbrial end and enters in the abdominal cavity, where it may implant at the peritoneal side or at the extraperitoneal side, that is at the broad ligament. This is another picture showing the different extrauterine sites for the implantation of an ectopic pregnancy: a cervical, interstitial, isthmic, ampullary region, fallopian tubes, and infundibular tubal, ovarian ectopic, and abdominal ectopics. The incidence of ectopic pregnancy increases in patients where there is increased history of pelvic inflammatory disease, or if she has a previous history of intrauterine contraceptive device, or if she has a history of previous tubal surgery, or she has an assisted reproductive technique. The recurrence of ectopic pregnancy increases with increasing number of ectopics. If she has past one episode of ectopic pregnancy, she has a recurrence risk of 15%. If she has 2 ectopic pregnancies previously, then her risk increases to 25%. The etiology of ectopic pregnancy may be congenital or acquired. In the congenital causes, if the patient has tubal hypoplasia, if she has congenital diverticuli, accessory ostia, partial stenosis, or intramural polyp, all these conditions increases the risk of ectopic pregnancy. In the acquired causes, pelvic inflammatory diseases increases the risk of ectopic pregnancy by 6 to 10 times. The different microbia which increases the risk of ectopic pregnancy, Chlamydia trachomatis is the most common. But in our population, as tuberculosis is also very common, so tuberculous PID also increases the risk of ectopic pregnancy. If the patient has previous history of contraceptive failure, or if she has been taking oral contraceptive pills or intrauterine contraceptive devices, these all increases the risk of ectopic pregnancy. If there is previous history of tubal reconstructive surgery, for example, she has bilateral tubal ligation followed by reconstruction, then the risk increases by 4 to 5 times. If the patient gives history of assisted reproductive techniques like ovulation induction, in vitro fertilization and embryo transfer and gifts, all these techniques increases the risk of ectopic pregnancy. If she has a previous history of one ectopic pregnancy, then she has 15% chances of a repeat ectopic pregnancy. Now, what is area stellar reaction? Whenever the patient conceives, that conceptus passes through the fallopian tubes, enter the uterine cavity, and the endometrial lining prepares itself for that conceptus with the decidual changes. So, area stellar reaction is characterized by a benign, focal, and unusual decidual change in the presence of the chorionic tissue. Though it is seen in ectopic pregnancy, but it is not specific for it, and it can also be seen in the uterine pregnancy. That's why area stellar reaction seen on ultrasound examination may be mistaken for an intrauterine pregnancy, where ectopic pregnancy is usually missed and the patient is received in the hospital in emergency after rupture of ectopic pregnancy. These are the two laparoscopic pictures taken. On the left side, we see a uterus with intact fallopian tube with a tubal abortion, where the ectopic pregnancy aborts through the femoral end and enters the abdominal cavity. And the picture on the right side shows another laparoscopic picture with a ruptured ectopic pregnancy. The ectopic pregnancy is diagnosed by history, detailed clinical examination, and with the help of investigations. If patient gives a past history of pelvic inflammatory disease, tubal surgery, if she is using contraceptive measures currently, then she should be asked about the pregnancy. And there should be high clinical suspicion of ectopic. The wide spectrum of clinical presentation from asymptomatic patient to other with acute abdomen and in shock. Ectopic pregnancy presents with a wide variety of clinical presentation. Sometimes we receive a patient who is completely asymptomatic and she is diagnosed incidentally on the ultrasound examination, and sometimes we receive the patient with acute abdomen and in shock. Now, acute ectopic pregnancy presents with a classical triad in 50% of patients with rupture ectopic. One of the most common symptoms is pain, which is a most constant feature in 95% of patients. The severity of pain varies from patient to patient. She may present with a history of amenorrhea, which is present in 60 to 80% of patients, with a short period of amenorrhea of 6 to 8 weeks, and spotting at the time of expected menses. The third classical feature is the vaginal bleeding, which is usually scanty, dark brown in color. She may feel nausea, vomiting, fainting attack, comes with syncope attacks due to reflex vasomotor disturbances. Sometimes she may give history of a shoulder tip pain, which in case of ruptured ectopic pregnancy, the hemoperitoneum irritates the surface of the diaphragm and the patient feels shoulder tip pain. On examination, the patient is usually restless, anxious, looks pale, with sweating and cold clammy skin. Features of shock, tachycardia and hypotension may be there. On per-abdominal examination, the patient abdomen is usually tense, tender, usually in the lower part, with shifting dullness, and rigidity may be present. On per speculum examination, there may be minimal bleeding in the vagina. On bimanual examination, the uterus is usually bulky, sometimes deviated to the opposite side. Fornix is usually tender and patient feels pain on movement of the cervix. Pouch of Douglas may be full and uterus floats as if in water. Chronic ectopic pregnancy. It can be diagnosed by high clinical suspicion. Patient may give history of a previous attack of acute pain from which she has recovered. She may give history of a short period of amenorrhea with vaginal bleeding and dull abdominal pain, sometimes with bladder bowel symptoms or rectal tenesmus. On examination, patient may look ill with varying degree of pallor. Sometimes the temperature may be raised, but the features of shock are usually absent. On abdominal examination, abdomen may have tenderness, there may be muscle guarding, and a mass sometimes may be felt irregular and tender. On vaginal examination, vaginal mucosa is usually pale, uterus may be of normal size or bulky, and an ill-defined bogey tender mass may be felt in one of the fornix in cases of chronic ectopic pregnancy. In case of unruptured ectopic, we must have a high degree of clinical suspicion. An ectopic conscious clinician can diagnose. Unruptured ectopic pregnancies are usually diagnosed accidentally through ultrasound examination or in cases of laparoscopy or laparotomy done for acute abdomen. The clinical features of unruptured ectopic pregnancies are she may have history of a missed period, she may give history of spotting with discomfort. On per abdominal examination, there may be tenderness or there may not be any tenderness. On vaginal examination, uterus is of normal size, it is firm, and a small tender mass may be felt in the fornix. Then we go for investigations. Investigations which are important in cases of ectopic pregnancies are transvaginal ultrasound, serum beta HCG levels, and laparoscopy. This is a picture showing an unruptured ectopic pregnancy with this white ovary and fimbrial end along with few blood clots. In recent years, in spite of an increase in the incidence of ectopic pregnancy, there has been a fall in the case of fertility rate. This is why, because there is widespread use of diagnostic tests and an increased awareness of serious nature of this disease. This has resulted in early diagnosis and effective treatment. And now the rate of tubal rupture is as low as 20%. The patient with acute ectopic pregnancy can be diagnosed clinically. When we diagnose the patient having acute ectopic pregnancy, the blood is taken for blood group and cross matching. 1 unit of blood is arranged. Full blood count is done along with hepatitis serology and coagulation profile. Patient is catheterized to keep intake output record. A urine pregnancy test is sent, which usually comes positive in 95% of cases because ELISA is very sensitive to even 10 to 50 milli-international units per ml of beta HCG. Beta HCG is a hormone which is secreted by the placenta, and it can be detected in the blood as well as in the urine. And the beta HCG can be detected on 24th day after LMP. In the past years, when the beta HCG and laparoscopy facilities were not available, the ruptured ectopic pregnancies were used to be diagnosed by culdocentesis. Culdocentesis is a procedure where a lumbar needle is passed through the posterior fornix into the pouch of Douglas. The plunger is pulled back to see the presence of blood clots or blood in the syringe. But nowadays we do not do cultocentesis. Ectopic pregnancy is diagnosed on ultrasonography. We can do transabdominal ultrasound as well as transvaginal ultrasound. Transvaginal ultrasound is more sensitive as compared to transabdominal ultrasound because it can detect intrauterine gestational sac at 4 to 5 weeks when the serum beta ECG levels are as low as 1500 international units per liter. On transvaginal ultrasound, the endometrial lining appears as a trilaminar pattern with a pseudogestational sac and a decidual cyst. What is a pseudogestational sac? All pregnancies induce an endometrial decidual reaction, and sloughing of the decidua can create an intracavitary fluid collection called as a pseudosac. So we must know the difference between an early gestational sac and a pseudosac. The early gestational sacs are usually located eccentrically into the uterine cavity, whereas pseudosacs are present in the midline. Early gestational sac has a round shape and a pseudosac has an irregular shape. Early gestational sac has double borders, whereas pseudosac has a single ring sign. On Doppler ultrasound, early gestational sac has high vascularity, whereas pseudosacs are avascular. The Doppler ultrasound sonography can also be done to diagnose ectopic pregnancy because it improves the accuracy. It identifies the placental shape and blood flow outside the uterine cavity, which reinforces the diagnosis of the ectopic pregnancy. Transabdominal sonography can also identify the gestational sac at 5 to 6 weeks when the beta HCG levels are more than or equal to 1800 international units per liter. These are the different pictures taken at transvaginal scans where a hyperechoic ring around the gestational sac is seen in the adnexal region. The uterine cavity is empty with a normal endometrial lining. This is another TVS picture showing a hyperechoic ring of the extrauterine gestational sac. Serum progesterone is another investigation which helps in the diagnosis of ectopic pregnancy. When the level of serum progesterone is more than 25 nanogram per ml, then this is suggestive of a normal intrauterine pregnancy. When the levels are less than 15, then it is suggestive of an ectopic pregnancy. And when the levels are less than 5 nanogram per ml, it indicates either a non-viable pregnancy irrespective of its location. Diagnostic laparoscopy is a gold standard procedure, but it can be done only when the patient is hemodynamically stable. It not only confirms the diagnosis, but the removal of the ectopic mass can be done at the same time. The differential diagnosis of ectopic pregnancies are ruptured corpus luteal cyst of pregnancy. It can be a rupture of a chocolate cyst or a twisted ovarian cyst or a torsion of a pedunculated fibroid or incomplete abortion. And the differential diagnosis of ectopic pregnancies can be acute appendicitis, perforated peptic ulcer, renal colics, or a splenic rupture. The management of ectopic pregnancy is either expectant management or a medical management or a surgical management depending upon the criteria and hemodynamic stability of the patient. Expectant management is done when the patient has minimal symptoms of pain, short duration of amenorrhea, the beta HCG levels are less than 1000 milli-international units per ml, and the size of ectopic is less than 3 cm where the fetus is dead. Patient is hemodynamically stable, then the patient is managed expectantly. Medical management is done when the patient fulfills the criteria for the medical management. That is, beta HCG levels are less than 3000, size of the ectopic pregnancy is less than 3 cm, where the fetus is dead or non-viable. Patient is in close vicinity to the hospital. Then a drug which is known as methotrexate, which is an folic acid antagonist. It inhibits the synthesis of the DNA. It is used in the management of ectopic pregnancy. It can be given systematically as an intramuscular injection, where dose of methotrexate is calculated depending on the surface area of the patient. The methotrexate can also be given as a local injection using ultrasound guided or a laparoscopic guided procedures, where methotrexate is injected into the ectopic site. The surgical management is either radical or conservative depending on the hemodynamic stability of the patient. If the patient is hemodynamically unstable, then we go for laparotomy, where salpingectomy is done. In cases of ruptured ectopic pregnancy, if the patient is hemodynamically stable, then conservative procedures can be done laparoscopically, such as salpingostomy, segmental resection, or milking of the fimbrium. The basic principles of management of ectopic pregnancies is resuscitation of the patient as well as preparing the patient for laparotomy or laparoscopy. The treatment of shock is given by maintaining IV line with 20 gauge cannula. Crystalloids or colloid fluids are given for volume replacement. Blood sample is taken for blood grouping, cross matching, arranging blood. CBC is done. Baseline investigations like serology and random blood sugar, they are also done. Patient is catheterized with a Foley's catheter, and then the patient is shifted to the OT for either laparotomy or laparoscopy. During laparotomy, the main principle is to do quick in and quick out. Quick in and quick out means that immediately the patient is opened, abdominal cavity is explored. Salpingectomy is the definitive treatment. The sample is sent for histopathology. Blood transfusion is given if needed. Sometimes autotransfusion may be given when donated blood is not available, and the patient is closed immediately. Another procedure which can be done apart from laparotomy is the laparoscopy, which is gold standard, and this is preferred method if the patient is hemodynamically stable, and it is followed by similar number of uterine pregnancy. Means the chance of intrauterine normal pregnancy is similar if the patient is treated laparoscopically. The advantages of laparoscopy are it has a shorter operative time and recovery of the patient is quick. The procedures which can be done during laparoscopy is salpingostomy, which means giving a rent or opening the site of the ectopic pregnancy at the antemesenteric border. If the size is less than 2 cm, 10 to 15 mm incision is given. The ectopic tissue is removed and the rent is left as such for secondary healing. Linear salpingostomy is indicated in unruptured ectopic, where the size is less than 2 cm in the ampullary region, where incision is given on the antimesenteric border over the side. The ectopic tissue is removed and incision line is kept open for secondary intention. The other conservative procedure which can be done in cases of ectopic pregnancy is linear salpingotomy. It's an incision line is given and it is closed in 2 layers with 7-0 interrupted vicral suture. Another conservative procedure which can be done for ectopic pregnancy is the segmental resection and anastomosis. It is indicated in the unruptured ischemic pregnancy, where end-to-end anastomosis is done immediately at the procedure. Thank you.